Thanks for joining us for another episode of Boom and Bust. I'm your host, Tony Clement. I'm here at the News Forum where all voices matter. The Macdonald-Laurier Institute research organization has recently released an important publication entitled How to Fund a Healthcare System on Life Support. This is critical, especially given the distress felt in the system during COVID. Here to discuss is Dr. Jack Mintz. He's the President's Fellow at the School of Public Policy at the University of Calgary, as well as Distinguished Fellow at the Macdonald-Laurier Institute. Welcome back to the program, Jack.
Oh, my pleasure, Tom.
I guess first, what can you tell us about the theme of this MLI paper?
Well, the piece that I wrote was really focused on, I guess, the area that I like working in the most, and that is how do you pay for the system? And I think that we're specifically focused on is that there'll always be a public portion to healthcare. In Canada, the government covers about 70% of the cost of healthcare services for Canadians, which is actually a bit lower than you find in Europe, and it's more than what you find in the United States. But the main point is that it's not going to disappear. And so the question is, how do we fund that? What's the best way of funding healthcare that the government provides to Canadians?
And what was your conclusion?
Well, I thought the Mazankowski report had a very good discussion of alternative measures. They discussed premiums, for example. At the time of the Mazankowski report, when it was issued, Alberta did have a healthcare premium. It also discussed other options, such as medical savings accounts, which we can get into some more detail afterwards. Also, what are called variable premiums, and even having dedicated taxes like an HST, et cetera. And what you do find today in Canada is that almost all of healthcare is just paid from general revenues, which is similar to the United Kingdom, but most other countries have some sort of dedicated revenue that goes to healthcare, including some incentive-based ones.
Now, let's just stick a pin in that just for a second. Obviously, Don Mazankowski, our viewers may not know, but he's a former deputy prime minister under the Brian Mulroney government of the 1980s and early 1990s, and he was commissioned to do this kind of future of healthcare report. I guess, was it in the late 90s or somewhere in there anyway? And from that came a series of recommendations. So you're kind of analyzing that and saying maybe he was slightly ahead of his time. Is that right?
I think he was probably not ahead of his time. It's just the question is whether Canadians are ever going to be willing to look at some alternatives. It did come out, that report, around, I forget exactly the year, but it was kind of around 2001 or whatever. And it was also at the same time that the Romano report came out. This was one that was commissioned by the federal government, which Roy Romano, who used to be the Premier of Saskatchewan, had put together a major report on healthcare reform as well. And so we had both of these reports out at the same time, and they did take quite different points of view, especially on the funding recommendations that I talk about in my paper.
COVID has been the icing on the cake a little bit here. It's a crisis that is with us now, but I guess your point of view is this crisis is a long time in coming, yes?
Well, back at the time of Mazankowski and the year 2000, expenditures in healthcare were rising quite rapidly, actually. Of course, we had relatively higher inflation going into the early 90s, and that was one of the reasons, but also the population was starting to age more quickly, and there were more people requiring healthcare services. And so it wasn't unusual for healthcare expenditures to rise, 6-7% per year. In fact, that went on even after the two reports were issued. It wasn't until we got till after the financial crisis in 2008 and the recession that followed in 2009 that we started to really see provinces control costs much more with healthcare. And in fact, the healthcare costs have not been rising as quickly as they used to be. But for all the provinces, healthcare is the biggest department and source of expenditure that governments make.
Jack, we're just going to take a brief
level.
break. I'm sorry to break in like that, but we'll take a brief break for commercial. We'll be right back with you. Welcome back to Boom and Bust. Dr. Jack Mintz, I had to cut you off there for the break. Please continue with your thought.
Well, I was just saying that, governments did, after 2010, they really started controlling healthcare costs across many of the provinces. However, healthcare is still a very expensive part of the provincial government portfolio of services. In fact, it takes up 40 to 50% of provincial budgets, and people used to comment that really there's only two major departments at the provincial level, and Tony, you may understand this from your own experience, but one of them is the health department, and the other is the finance department. Yeah. And so health is still a very big item. And I think what's happened with COVID is that after years of constraining costs this past decade, we have made the system more efficient compared to what it used to be. But we've also cut back services to some extent. And COVID, I think, laid bare some of the issues that are part of the healthcare system, where it's had to ration healthcare for Canadians as a way of trying to control costs to some degree.
Yeah, and I would say from my own account, as a former provincial and federal health minister, it's always tough being at the table, especially at the provincial level, always demanding more money when people around the cabinet table are saying, well, we need money for roads, we need money for schools, we need money for public safety. There's only so much money going around, so it's a constant refrain, and it hasn't gotten any better. Why do you think governments have avoided solutions on this issue?
I think part of it is that healthcare is like the third wheel when it comes to Canadian politics. We've gotten into let's say, a way of thinking that somehow Canadians shouldn't have to pay out of their pocket for for expenses. Although we do it, I mean, people pay for their own dental care, they pay for part of the cost of drugs, they pay for cost of home care and long-term care. It's hospitals and physicians that people don't pay for. And yet when you go to the European countries, you'll see that there's user fees in some of the countries. There's parallel systems where you have both private and public available. They also have deductibles as part of an insurance system for healthcare. So all those things are provided, and in those countries they try to have a very good balance between public and private systems, and at the same time giving people some options, which also allows for more competition in the system. Those sorts of things have been resisted tremendously in Canada. And in fact, that showed up in the Romano report. It objected to anything along those lines, unlike the Mezinkowski report, which said we need to look at other options to fund the system. And of course, when you start having rising wait times as we've had recently, I think it's going to put a lot of pressure on governments to do something about wait times that are getting well out of hand.
You mentioned other jurisdictions, Europe, UK, and so on. Are there things to be learned on how they finance the healthcare system then from them?
Well, I think that you'll find not so much the UK, they kind of do what we do and just use general revenues. But you'll find, for example, in the United States, you now have the Affordable Care Act, which is a form of government funding of healthcare. There's deductibles involved and subsidies for people. People still pay some premiums out of their, to cover it. But it is actually now listed by the OECD as a form of government funding of the system. You'll find that in some countries you have funds that have been built up through payroll taxes. That includes the United States, which have been dedicated to healthcare, and that is another option that one can think about. And I think in Canada, we have not done any of that. And in fact, I would argue that we should really look at some alternatives, of which my favorite one actually is the variable premium, which I think has has something to it, especially in that it can achieve a lot of the objectives that we're trying to achieve.
Sorry, what's a variable premium?
Variable premium would be one in which people would be assessed a premium, a healthcare premium, as a certain percentage of their healthcare benefits. So it requires governments to do accounting of the whole healthcare system, which means that they need to know the cost of operations and other procedures that are used in healthcare, which they currently really don't know very well, which is part of the problem in their budgeting. But the amount that people would pay would be limited to a percentage of their income, let's say like 3%.
We're back with our conversation with Dr. Jack Mintz. Jack, please continue with your explanation of how this premium would work.
Okay, so the variable premium could be something like 25% charge on healthcare benefits. It would be limited to, let's see, being no more than 3% of income. So it'd be somewhat like the Ontario premium right now, which is related to income. But it would also provide an exemption of the lower income groups, so low income people wouldn't have to pay it. And what would be interesting about it is you could run it through the income tax system, so people would not have to pay out of their pocket. If they don't have the money for their healthcare services, it'll be settled up at a later time. The scheme that we had worked out a number of years ago would raise roughly $5 or $6 billion for healthcare. It would also create some incentives because people would then know that when they phone up many different doctors for services, they're going to end up having to pay a little bit more, which I think puts some impact, or at least makes people think a little bit more about how they use the healthcare system, because it was well known that some people had overused it. And so I think a lot of those things, I think, would make sense as an option for financing, running it basically through the income tax system. Of course, we could have just a healthcare premium like the one in Ontario, or the one that Alberta used to have, and make it sensitive to income levels. And that could be dedicated, put in a fund to fund healthcare. I would be fine with that. And even if we thought about having GST, part of the GST being dedicated, or the HST in some of the provinces being dedicated to healthcare, that would also make some sense if one wanted to do that, especially if you start building up funds, because we are going to go through a very fast aging in the population this decade. It's coming on a lot now. In Canada, currently 17% of the population is over the age of 65. That's going to rise to 22% by the end of this decade. Right. That's a huge change. And it means also there's going to be a lot more demand coming onto the system. In the meantime, we have waiting times that have now lengthened for many procedures after COVID. And so we need to put more money in the system, I think. And it would be nice, I think, it's not just going to be solved by, trying to cut expenses and efficiencies. We're going to still have to do that. But I think we're going to have to put some more money into the system. And I think thinking about some alternative ways of doing it, which are acceptable to Canadians, that would be very important.
Yeah, and have you noticed, though, that obviously there's this real fear, quite apart from additional money from the user of the system, but there is this fear of for-profit healthcare in this country. How is that? Can that be overcome, or is it just impossible to have that conversation?
Well, we already have for-profit healthcare, as I mentioned, in non-Medicare services, but even in Medicare, we do have private supply of medical services that are still paid for by the government. Mm-hmm. For example, creating clinics. In fact, there's ways of thinking about running the healthcare system, such as contracting out services, rather than just simply having a government body running the services. So to give you an example, suppose that doctors create primary networks, which everybody recommends as a way of trying to control the system, as you have a gatekeeper, which is what the UK does in their system. It allows you a much more integrated approach and patient-centered approach to healthcare. That could be done as a contract between the government and the primary doctor, and then behind the primary doctor are other doctors and specialists that the doctor would recommend to use. And that is an approach that I think would make eminent sense, but certainly is one way in which you can create more, let's say, competition and private supply within the system. Same thing applies to clinics where you get various procedures done, whether hip replacements or whatever. There's no reason not to do it. And of course, there are already private clinics you can go to in almost every province for certain purposes, which cover things that Medicare doesn't cover, but then at the same time, they'll recommend or provide the Medicare services that people are looking for. And that is another form of private supply. So we're already doing that to some extent. And I think Ontario's been very good, particularly at expanding private supply of publicly funded medical services. And as a result, they have many clinics where you can get different procedures as opposed to just going to one or two hospitals that ends up getting overloaded instead.
And we're back here at Boom and Bust with our guest, Dr. Jack Mintz. Jack, obviously for decades, Canadians were told by governments that their system was superior, and yet here we are still with hallway medicine. And as you mentioned, COVID is going to make things worse because of all of the effort that was put into that versus dealing with wait lists. So is that the purpose of the report, to try to start the debate going on a very serious topic?
I think so. I mean, Macdonald-Laurier Institute is directed by Brian Crawley, who actually was on the Mezinkowski panel. And so he thought it would be nice to have some papers done to look at healthcare following the ideas of the Mezinkowski report. And so he had 3 papers written. There was Janice McKinnon wrote one on healthcare services. She's certainly a great expert on the topic. And he also had Jeff Simpson write about the politics of healthcare. And obviously, Jeff did a terrific job writing that. And I was asked to look at the issue of financing healthcare, which is what my paper was about.
And do you think that the time is now then that people will take this debate seriously, and that we can help turn around the system? Is that the hope?
I think that the increase in wait times now is really a serious matter. Just to give you an idea, somebody I know quite well in Alberta needed to get a hip operation, and the wait times aren't even properly measured because they just measure it from the time you get a consultation and then how long it takes to get the operation done. But actually, it takes a long time just to get the consultation. And in fact, he had to wait 6-8 months just to talk to a specialist. And then he was told another year before he could get the hip replacement done. So he ended up going down to the United States and doing it. He was able to afford it.
Right.
The main point is that that's not really great healthcare, because many people in Canada can't afford doing that sort of thing. Even my own case in Ontario, just to get a consultation with a doctor, I have a specialist. It took 4 months just to have a phone call. And I just don't think that's appropriate. And I do know the numbers. I'm on the board of Alberta Health Services, and I see actually right now what's going on with wait times, and where we're well beyond what are even the targets. And the targets for what the wait time should be are pretty, let's say, liberal, in the sense that they're very high in terms of the wait times, and we can't even meet those targets. And so, if you say you got to, jump, be a high jumper, and you set the target in such a way that's really only 1 foot to jump, it's easy to do. But if you set the high jump to be much higher, like 6 feet, it could be much more difficult. We're setting it at 1 foot in order to meet the target, when we really should be meeting at a much higher level. And so I think this is really a very serious issue that I think is affecting every province, from what I know. And I think that it means that Canadians waiting a long time for services and getting sick in the meantime are going to start demanding some sort of change. And I guess that will be when the debate will come in about how we going to achieve that.
We've got about 30 seconds left. Are you optimistic that these changes can happen?
I don't know. It's such a difficult political issue. It takes real leadership, but maybe when things get bad enough, people finally force change. And I think that I am hopeful that actually that might come around this time.
Well, hopefully COVID has opened the eyes of some people to, what was going on in the system before that. So thank you for your contribution and for your colleagues' contribution at the Macdonald-Laurier Institute for this very important debate, and hopefully it'll make a difference. Jack Mintz, thanks for joining us today.
It's my pleasure, Tony. Thank you.
Very important discussion with Jack Mintz there, representing the Macdonald-Laurier Institute on the future funding for healthcare, which has to be sorted out if we're going to have services that we need in the future with our population aging. So thanks for joining us for that very important discussion.